Hello everyone. My name is Dr. Simarpreet Singh Anand, and today I'll be talking about high flow nasal oxygenation. Some of you might call it as Thrive or HFNC, but the principle behind it remains the same. So, I've made this lecture. First, we'll talk about the basic physiology required to understand the basis of HFNO, different types of oxygen therapy we have, how HFNO works, indications, basic contraindications, and how do we monitor the patient while they are on HFNC and its use in COVID era. So when we are taking room air, so we are breathing in FiO2 of 21% at 1 atmosphere. And as we take in the air, it gets humidified in the nasopharynx as well as the oropharynx, around 80% in the nasopharynx and around 70% in the oropharynx. And when we expire, we exhale the CO2 via the same route. But once we take the next breath, it get diluted by the CO2 already present in the nasopharynx, along with water and nitrogen as well. So this is the basic slide which you need to know to understand HFNO, that is a peak inspiratory flow rate. So what I mean by this is how fast we breathe in. So normally we breathe in a tidal volume of around 500 ml. So to breathe in that 500 ml of air from the atmosphere to the lungs, we need to have certain velocity, which is around 25 to 35 liters per minute at rest. Supposedly we are running and we get breathless, so we start increasing this peak inspiratory flow rate as high as 60, 70, and so in ARDS or pneumonia. So we try to take in that air as fast as we can. So if just I have to explain this concept, just think of 2 points A and B. So if I have to move from A to B, I can either walk or I can either run. So if I walk, I'll reach there a bit later as compared to if I run. Same way, if I'm breathing with a peak inspiratory rate of 25 to 35 liter versus a peak inspiratory flow rate of 60 to 100, obviously the air will reach in faster with a peak inspiratory flow rate of 60 to 100 liters per minute. So if I have to classify basic oxygen delivery devices, I can just classify in as low flow or high flow devices. Low flow being the nasal cannulas or Hudson mask, and high flow being HFNO or Venturi masks. So nasal cannula. So basically, this concept needs to be understood that we deliver 100% oxygen via the nasal prongs, but what reaches the patient is not 100%. So how I explain this is, I have already explained you the peak inspiratory flow rate, and normal peak inspiratory flow rate is approximately 30 liters. So imagine if I am giving my patients around 5 liters of 100% oxygen via face mask. So that is 100%. 5 liters will be 100%. But the rest of the 25 liters, the patient has to take in from the atmosphere. That is 21%. So as it moves in, it gets diluted, and the final FiO2 which the patient is receiving is not 100%. So coming back to the slide again. So this is basically, this was calculated on a peak inspiratory flow rate around 25. So if we are giving a patient 1 liter per minute, the FiO2 we are delivering to the patient is not 100%, but 24%. And we just add 4% as we increase our flow rate. So just concentrate on the image above. So imagining my patient having a peak inspiratory rate of 35, and I'm giving him a flow rate of 5 liters of 100% FiO2 by a face mask. Still, the patient has to compensate with the rest of the peak inspiratory flow, which will be taken in from the atmosphere, resulting in a low FiO2 as compared to what we are delivering to the patient. Simple face mask stem, we can deliver 100%. We deliver 100% from the machine, but what reaches the patient is not 100%. Plus, it has imperfect fit as well as venting holes. So non-rebreather mask, which has been used in COVID era as well. So coming to the gist of the talk, the HFNO. So this is the basic HFNO machine. So we can set the FiO2 from here, the temperature from here, and the humidification, the percentage of humidification we require from here, which is delivered via these tubings to the patients. So if I have to define this, so it's a system that provides oxygen as well as gas mixture at flow rates which meets or exceeds patient's inspiratory effort, along with appropriate humidification and warming. So I'll be explaining you this. So what are the basic indications of HFNO? The main being the hypoxic respiratory failure, post-surgical patient, or even this is also used for pre-oxygenation nowadays, for weaning, pulmonary fibrosis, sepsis, and also mild COPD with exacerbation and asthma. As HFNO basically provides optimal humidity and flow. So due to this optimal humidity, we have mucociliary clearance as well as comfort. So what I mean by this, imagine I'm delivering 10 liters of 100% oxygen via nasal prongs. So the amount of air that is going through the nostrils will dry up the secretions, because most of the secretions will be required to humidify that much of air, which gradually will increase the work of breathing. And imagine if we are giving flow rates as high as 45 liters, what it will do to our nasal mucosa is just erode it and the patient will land up in epistaxis. So imagine if we have a device which can provide this high flow rates around 45 to 60 liters, also maintain a temperature of around 37 degrees C and also humidify the air. So we can well imagine that the work of breathing will gradually decrease. So coming to the image below, so I've already talked about the image above. So now imagine we are giving the patient 35 liters per minute. That is his or her peak inspiratory flow. So we have replaced all the peak inspiratory flow with 100% FiO2. Obviously, the patient will receive 100% FiO2. There will be no dilution. Thereby, the patient's saturation will improve and the work of breathing will also decrease. What we are trying to achieve via HFNO is that we'll relieve hypoxemia, we'll deliver the desired oxygen concentration, as I already explained, we'll maintain comfort and compliance, and reduce the potential escalation to the therapy. So basically, it's a bridge between uh, the conventional oxygen therapies to intubation. So this I have already talked. So how it works? So basic mnemonic is high flow itself, HIFLOW. So I'll be talking about each and everything. So heated and humidified. So just look at the image below. So it's the basic steamer which we use when we have a nasal congestion. So the basic how we use it is we take in deep breaths, thereby increasing our peak inspiratory flow rate. Plus the steam is humidified. So this is the only basis behind HFNO as well, isn't it? So we provide our patient warm and humidified air, which are warmed up to 37 degrees C. So gradually this decreases the work of breathing, increases the mucociliary function, and also increases the secretion clearance. Inspiratory demand, as we see, if we run, we pant, and by panting, we gradually increase our peak inspiratory flow rate, as I already explained. So in ARDS, we can have a peak inspiratory flow rate as high as 60 to 120 liters per minute. So we are aiding our patient with that high peak inspiratory flow rate so that our patient have a decreased work of breathing. It also helps in providing PEEP. So there's around one PEEP for every 10 liters per minute of flow. So thereby it also increases the FRC. And it's a lightweight device as compared to the conventional CPAP or BiPAP machine, which the patient just wants to rip it off from their face. And so therefore having a better compliance as compared to CPAP and BiPAP. And O2 dilution, obviously, there won't be any O2 dilution because everything, the peak inspiratory flow is provided by the machine itself. That is 100% oxygen, which I have already talked. So there won't be any dilution. So we can have FiO2 of 100%, which is delivered to the patient. So, uh, so this is the same way. So now imagine the patient is having a peak inspiratory rate of 120 liters. The patient is in ARDS. And we just provide him with 10 liters via nasal prongs. The rest of the 110 liters will be taken up from the atmosphere, that is 21% O2. Now imagine the dilution of oxygen the patient will be doing, and we'll have an unpredicted saturation which the patient will achieve eventually. So that's why the conventional oxygen therapy are not useful. So also there will be washout of the dead space. The nasopharynx will be completely filled with the oxygen. So with each breath, the patient won't be rebreathing his exhaled CO2. so thereby increasing the PaO2. So what are the goals? So we reduce there is a reduction of the dead space. There is dynamic positive airway pressure, as well as we supplement oxygen. There is airway hydration and obviously patient comfort. So when the patient is on HFNO, the patient can eat, drink, talk, and communicate as well as sleep with that. So therefore, the patient is have we have better compliance with high flow nasal cannulas as compared to NRVs. So, but we should also monitor the patient timely. So once we have started our patient on high flow nasal oxygenation, the heart rate should gradually decrease within 10 minutes, the respiratory rate around 15 minutes. His saturation should increase within 10 to 15 minutes. The patient should have a decreased work of breathing, leading to a decreased dyspnea, decreased supraclavicular retraction, and thoracoabdominal asynchrasy. So we should monitor these things as soon as we have initiated HFNO on a patient. So oxygen should be used as a drug, and we should start thinking of weaning as soon as we have started the patient on some kind of oxygen therapy. So the order of weaning in HFNO should be: we first decrease the FiO2, followed by we decrease the flow rates, and then we gradually wean the patient off the HFNO and take him on some other type of like Hudson mask or nasal prongs. So physiological outcomes of HFNO will be there will be improved oxygenation since we are delivering a prescribed FiO2. There will be reduced work of breathing, and obviously there will be increased end expiratory lung volumes. There are certain contraindications as well. One being type 2 hypercarbic respiratory failure, type 4 respiratory failure. There is untreated pneumothorax or pneumomediastinum. The patient is having epistaxis, base of skull fracture, and the patient is having an impending intubation. So it's not a foolproof thing that your patient won't land up in intubation. So if your patient is requiring intubation, we should do it as soon as possible. So there's a scoring system as well, which we can use to predict the um, success of HFNO, that is known as ROX index. It's calculated by SpO2 by FiO2 by respiratory rate, and a value of 4.88 is taken out. So its role in COVID. So this article is one of the best which I have found, and it calculated it that decreased the rate of intubation required in COVID patient as compared to those who were not initiated with HFNO. HFNO can also be used along with COVID awake repositioning and proning protocol because it's a lightweight device and the patient can easily lie down and even can get prone with using this. But there are some drawbacks as well. Since it's using a very high flow, peak inspiratory flow rates, so it also aerosol generating, which can be dangerous for the healthcare workers working in the COVID wards and ICUs. So a simple way in which we can tackle this is we just apply a simple triple layer face mask on the patient. In this study, we can easily see the image above is without the face mask. The patient is having a larger aerosol spread as compared to when the face mask was applied. The aerosol generation spread decreased eventually. So what are the predictors of failure? So the respiratory rate is still not decreasing. The saturation is not improving. The patient is still needing extra muscles to having to breathe. The patient needs vasopressor and sophoscope. So along with that, in second wave, we saw that as the number of patient increased, high flow nasal cannula requires a lot of oxygen. So we landed up in oxygen crisis eventually. And so if we have to compare HFNO with all the other device, so it has greater mucociliary clearance, it has good comfort, accurate oxygen delivery. We have washout of dead space as well as we also have some kind of a PEEP which we can provide the patient along with this. Uh, it's a simple thing. It's a bridge of humidify, low flow oxygen flow, and face mask. We can just use this instead of this. And once the patient is requiring non-invasive ventilation or invasive ventilation, we should not delay it just because the patient we have put our patient on HFNO. So thank you so much, and I hope you learned something from it.